talk about high-risk disorders of pregnancy. And that way, then we can do some fun things in class, virtual class on Monday versus me having to lecture. So I'm just going to give you a brief overview of the disorders. The two big ones I want to really make sure you understand is gestational hypertension or preeclampsia. There's all different sort of categories of high blood pressure in pregnancy. And then definitely the difference between gestational diabetes versus someone who has pre-existing diabetes and how those are a little bit different. However, the first things we're going to talk about are the hemorrhagic conditions of early pregnancy. So these are miscarriages. We use the word abortion to mean someone. It can be something that's oh my gosh, why am I not thinking of the right words? I'm sorry, here we go, spontaneous. So that's what I'm looking for. So spontaneous abortion is considered a miscarriage. And it really is a leading cause of pregnancy loss, depending on what books you look at. Some will say up to 20% of pregnancies end in miscarriage. Typically, what they say is that there was something, some sort of chromosomal issue that was going on. The older you get, the more at risk you are for it. Certainly, there is a huge emotional component to it, especially if someone who is having habitual miscarriages and they continue to have one miscarriage after another. It can definitely take a toll emotionally. It can take a toll in the couple, all different kinds of things. So we think of miscarriage as prior to 20 weeks. Often most miscarriages are very early in pregnancies. And the biggest thing that we really want to pay attention to when someone has a miscarriage is we want to make sure they don't go into shock or have infection. And then, of course, the whole emotional component to it. Another thing I want to make sure that you guys know is that if someone is Rh negative, so A negative, O negative, AB negative, and they have a miscarriage, they need to get RhoGAM. Okay, so you always need to know what a mom's blood type is if she has a miscarriage. So these are all the different types. So you can have, sometimes people have vaginal bleeding, and it's sometimes actually what they'll end up having is just like a little abruption, a mini abruption in their placenta, and some of that blood trickles out. And really, as long as the heartbeat's still there, they just keep watching and see what happens. Sometimes they'll call it threatened. Sometimes they'll say, rest, but really there's nothing you can do before 20 weeks. It's either going to end up in a miscarriage or not, sadly. I mean, certainly you wouldn't want those people to have sex or anything like that. But at that point, there's not a whole lot you can do but just sort of hope and see what happens. Once someone is bleeding heavy, and especially if they're passing clots and it's in the early 20 weeks, it's inevitable. And, typically they'll do an ultrasound, a vaginal ultrasound, a transvaginal ultrasound, where they have to go in through the vagina because it's too low in the uterine segment that you could see with a Doppler on top or an ultrasound machine on top. Usually that's not until like 16, 17 weeks that you can use an ultrasound machine on top to see things. If someone has an incomplete miscarriage, so typically what will happen with this patient is they'll pass some clots, they'll pass some blood, they'll have some cramping, and then they'll continue to have cramping and continue to bleed, and it just doesn't end. Those people typically need to go in and have what's called a D&C, a dilatation in curettage, I think is how you say it, curettage, where they go in and they scrape out the inside of the uterus to make sure all the pieces come out of tissue and things like that. Pieces of tissue and blood clots and things like that. So a mist is basically where someone goes in, these are always really hard, is they go in for an ultrasound at, somewhere between 6 and 8 weeks and there's no heartbeat and they just never bled, and either the bleeding will start. So sometimes they'll say, let's just wait a few days and see what happens. But if they don't end up starting to spontaneously abort the baby on their own, sadly, they'll have to go in and they can either do two things. They can give a drug like Cytotec that if it's early enough that they put in to the cervix and it causes enough irritation that sometimes it'll and enough cramping to expel. However, if that doesn't work, then they have to go in and do a D&C. And then a habitual abortion is someone, sadly, who has 3 or more consecutive pregnancies end in miscarriage. And that is absolutely, heartbreaking for many, many families. And they're seeing specialists and whatnot. So here's just kind of pictures, and you can see this is that threatened abortion. So there's some bleeding happening. There looks like maybe a little bit of an abruption up here. These sometimes resolve, and sometimes the babies end up okay. Inevitable. There's, before 20 weeks, the membranes have ruptured. There's blood clots coming out. It's inevitable. The cervix is starting to dilate. Where this is really sad is, it's always sad, but certainly if you have 16-week or 17-week, sometimes these babies are going to be born still with a heartbeat, and that's always really sad. And we have moms hold the babies, and they're really little, but we certainly try to have moms at the closer to 20 weeks and the more kind of formed the baby is, let them be able to grieve and see the baby and whatnot if they want. The baby won't live for very long sadly, once they're born. And then an incomplete is when part of the fertilized egg that did not, grow into a baby comes out, and some of the placenta comes out, but there's still some left. And then they go in and they scrape out the inside of the uterus. Here's, you can see the placentas, like here's all those spiral arteries, right? Isn't that interesting? So this is where a little abruption would be, probably right around here maybe. Okay. So one of the things we worry about whenever anyone has a hemorrhagic condition of pregnancy, whether it's abruption, remember abruption, board-like abdomen, that's when there's that shearing that causes the placenta to pull away from the abdominal wall or the uterine wall, or previa, where the placenta actually grows either close to the cervical os, the cervical hole, or completely on top of it, or a miscarriage, or any kind of disorder that could cause bleeding in pregnancy. One of the things we delivery too, we worry about is someone going into disseminated intravascular coagulation. And I don't want to go too much into this because you will touch on this in med-surg, but DIC is one of those coagulopathies where people clot and then bleed, and then clot and then bleed, and then clot and then bleed. And it's sort of like the body goes into this whole confused state, and hemorrhaging for whatever reason triggers it. And it's like they start to clot and clot, but then they start to bleed and bleed. And you have these little micro clots that get stuck in the microvascular vascular part of the body. And you can go into, the biggest fear is you go into multi-organ system loss, and then unfortunately these patients can die. So DIC is incredibly scary. Some of the things you look for with DIC is if someone's IV site is bleeding, are their platelets really low? Are they, a lot of, bleeding from different orifices, things like that. And these moms need to be in the ICU. And really, there's not a lot they can do, but try to really a lot of support, IV support, and keep the blood pressure up, and lots of replacement of fluids and blood and things like that. But multi-organ system failure is not something you want to go into. So that's just a quick little thing on DIC. I feel like this is sort of like a hard topic with all the miscarriages and things in the beginning. Ectopic pregnancy, we've talked about this before. This is when, in the next picture, you can see it, the fertilized egg somehow implants somewhere in the fallopian tube. One of the reasons why people are at risk for ectopic pregnancy is, let's say you have an IUD, right? An IUD would sit here in the uterus. So the fertilized egg comes down and is like, whoa, and it goes back up because there's nowhere to implant. Let's say someone has a history of sexually transmitted diseases. Maybe they have scar tissue inside, or they've had pelvic inflammatory disease, or they have endometriosis, right? Or they have anything, they've had abdominal surgery or something that's caused scar tissue. If there's scar tissue and the egg can't find a place to implant inside the uterine wall, it will boop, 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 go back up. What I want you to know about ectopic pregnancy is that it is a medical emergency. If the tube ruptures, that mom can hemorrhage and die very quickly. So many of these patients will have a positive pregnancy test, have some spotting in early pregnancy, 6 weeks, 7 weeks, 8 weeks, and often they will complain of pain that is either on their right or their left side. So if someone is complaining of unilateral pain on one side, and they're having possibly some spotting, and they have a positive pregnancy test, they need to have an ultrasound done to verify where that fertilized egg is. Because it is a medical emergency, and you want to try to save you want to try to save someone's fertility too, and not have to lose the tube. So the way they treat it is methotrexate it's a chemotherapy drug that can be given. It's given in a shot, and it somehow causes like the absorption of the egg so they don't have to go in and do surgery. If the methotrexate doesn't work, then they'll go in and have to actually remove it. So another thing I want to talk about is what's called a molar pregnancy, or it's called gestational trophoblastic disease. And sometimes it's referred to as a hydatiform mole. Those are all kind of the same things, and it's basically very confusing for patients because they will have a positive pregnancy test, but there's actually never been a heartbeat or a fertilized egg. Basically, that like doesn't exist. Instead, just the placenta develops, and it's this abnormal cell growth. And so, they feel like they're pregnant. However, they're passing what are like grape-like little clots, basically, and it's almost like a cancer in that it's just this, for whatever reason, the sperm and the egg meet, and instead of developing a fertilized egg and a heartbeat, it's just more like this placenta develops. So there's not really ever a baby there, which can be very hard for people to understand. And it's really sad because these moms have to be watched very closely for the next year to look for any kind of malignant changes. They're to increase risks of uterine carcinomas moving forward. But typically they can go in and just scrape it out, and again, like evacuate the molar pregnancy with the D&C. But it is something, this will show you, it's like this it's basically a cancer. And so they'll pass these little clusters and they have to go in and scrape all this out. And then they'll be doing uterine samples, tissue samples really for the next year to make sure that they're not, they'll do a endometrial sample to make sure that the lining of the uterus is not showing malignant changes. So that's called a molar pregnancy, a hydatiform mole, or gestational trophoblastic disease. It's all the same thing. Okay, so some disorders that can occur during pregnancy. One is hyperemesis gravidarum. This is a very, very, very severe form of morning sickness. Most people's morning sickness, most people will have some nausea and vomiting that does, that progesterone causes that, and because it causes, right, it slows down, just like it causes constipation, it slows down your whole intestinal tract, which can cause nausea. But usually by 16 to 20 weeks, people's nausea gets significantly better. This is debilitating. These moms, they also spit a lot too. They have this like kind of saliva that builds up. But these moms are often in the hospital for IV fluids. IV fluids and electrolytes are the number one goal of treatment. Is the first thing, is restoring fluid balance and getting their nutrition maintained. Occasionally, these moms will actually end up in the hospital on parenteral nutrition, so like TPN, because they absolutely can't keep anything down. This is a pretty debilitating disease, and I mean, it's just a miserable disease. It's not necessarily harmful to the baby as long as they can keep mom hydrated and keep her nutritional status up. It's just, they end up with PICC lines placed, and these are a lot of our like frequent flyer antepartum patients, is our hyperemesis patients who would come in for IV anti-nausea medications, possible TPN, then go home, but then come back when, as it would flare. And this is kind of a hard disorder. And typically sometime, not immediately after delivery, but usually within a week or two, they start to get much, much better after delivery. So now we're going to talk about hypertension during pregnancy. So you have a whole bunch of different sort of terms to use when we discuss hypertension during pregnancy. So the first thing we talk about is gestational hypertension. So this is someone who has a normal blood pressure at their first prenatal appointment. And this is why we take blood pressure at every single prenatal visit, because we're really looking for trends and trying to figure out what happens. We know that people will have a natural decrease in blood pressure because even though you have an increase in blood volume, you have a natural relaxation of your vessels, which causes the dilatation of your vessels. And so naturally, we will see women actually trend down a little bit in their blood pressure during pregnancy. So if you have always had a normal blood pressure, all of a sudden you start to develop some hypertension, we're going to start looking for that. We're going to start watching for preeclampsia, because basically preeclampsia is a disorder that occurs with basically you have this sort of increase in blood pressure, and then you have vasoconstriction occurring throughout your body in different body systems, which cause the different symptoms. So you have protein in their urine. Some protein may be, a little bit of protein is normal, not a lot. because you start having vasoconstriction in your kidneys. Then you start having vasospasms. You can have it in your cerebral vascular area, and these people are at increased risk for seizures. Preeclampsia, the whole thing with preeclampsia is, do you deliver or let the baby cook? Do you deliver or let the baby cook? Because the only cure for preeclampsia is delivery. That is the only cure. Now, we may use labetalol to keep mom's blood pressure in a safe range because we don't want her to stroke from a high blood pressure, but that is not curing preeclampsia. We may treat mom with magnesium sulfate because that is a central nervous system depressant, and we are trying to keep her from having a seizure, and so we do that to just relax the central nervous system, but it's not cure. The only way to cure preeclampsia and to prevent eclampsia is delivery. So let the mom cook, let the baby cook, go ahead and deliver. Let the baby cook, go ahead and deliver. So these moms are going to be watched very closely, because think, if you are having vasoconstriction throughout the various body systems, what else are you also having? You're also having this in the placenta. So these moms are going to need non-stress tests starting at 32 weeks, right? Possibly earlier, but at least at 32 weeks, because we need to see, is baby tolerating what's happening to the placenta? Is baby tolerating these blood pressures? Okay, so gestational hypertension is just that. It's hypertension after 20 weeks of pregnancy. There's no proteinuria. It can turn into preeclampsia, so these moms are being watched very carefully. And if it continues for 6 weeks after, we're going to say, hey, she has chronic hypertension. It just was never caught. Because remember, a lot of these moms have never had, I don't know, for the first time I got pregnant with my first child at 28, I don't know if I'd gone to the doctor in a couple of years. These moms aren't necessarily at an age where they're, being really good about their health care. And we know there's a natural decrease in blood pressure that happens in that first half of pregnancy. So once you get through that first half of pregnancy, if all of a sudden you start to see this gestational hypertension, it could just be chronic hypertension. So here, this explains how circulation and hormonal changes cause the blood vessels to dilate. So you do have this kind of lowering of blood pressure in early pregnancy that happens. Therefore, gestational hypertension, sometimes doesn't show up until 20 weeks. And then sometimes it's chronic hypertension that just had never been caught and got masked by what happened during the early part of pregnancy. Does that make sense? So then preeclampsia is this kind of generalized vasospasm that constricts and kind of messes with the circulation to all the different organ bodies. So you will see liver enzymes are going to be watched. So if I am sending labs on a preeclamptic mom, because one of the things we do is we monitor blood pressure, we monitor protein in the urine, we monitor different labs, and we're looking for an increase in all of the symptoms of preeclampsia that will show us there's an increase in the vasospasms that are happening. And one of the things that can lead to is eclampsia, which is a seizure, and we really want to prevent that. So let the baby cook or go ahead and deliver. So if you have hypertension and you have protein in your urine, we are thinking that you actually have preeclampsia and you have this sort of generalized vasospasm happening. 140/90 is considered high. So anyways, you're also going to have swelling in your hands and face, not just that dependent edema that moms can have, but because they're having this vasospasm, right, all the fluids are kind of getting messed up. So a mom with preeclampsia may show up and her face looks swollen, her eyes are swollen, her hands are swollen. She says, I gained 5 pounds, in a day. So these are all things we're paying attention to. This is why we take weight checks at every single appointment. We're not only looking for, from a nutritional standpoint, we're looking for, maybe some sort of shift in fluids that is happening that could be an indication that preeclampsia might be setting in. One of the moms, and some are insidious. Some blood pressures may be 130s over 80s, but maybe this mom was naturally 100/60. Right? So for her, that's high. So that's why it's very, very important. We always know what the trend of their blood pressure is and what they started out as. One of my patients, when I was doing triage at the doctor's office, came in and she asked me to turn the lights off. And I said, oh, how come you want me to turn the lights off? And it's because she had a headache and the lights were bothering her. Well, that was a huge red flag. Guess what? Her blood pressure was high. She had protein in her urine, and that was her ticket to the hospital. Now, these moms can be induced. For sure, they don't necessarily need to have a crash C-section unless, they look like they were going to stroke or something like that. But they need to be monitored. And so often they'll sort of be in the hospital for a while to see what's going on. Let the baby cook a few days while we watch. Sometimes they can actually they'll do an amniocentesis and they can test a fluid to see this ratio and see if the baby's lungs are developed. If they're not, maybe they try to buy a few more days. And that's called the LSPG ratio, and it looks for lung development, and it's done through an amniocentesis. So sometimes that can be done to buy time or try to, see what's going on or see if it is okay to deliver. But these moms definitely need to be monitored closely. So blurry vision, headache, not just a headache like, allergy headache, but really out of the normal, and their eyes are bothering them, they're light sensitive, all of those things that show CNS irritability, right? So if they're having central nervous system irritability, we are concerned that there's some vasospasm going on that's messing things up, whether it's from fluid, whether, all different kinds of things, and these moms are at increased risk for having a seizure. So here's just some kind of generalized edema. You can see how the orbitals around her eyes are a little bit swollen. That shows pitting edema, right? It's probably 2+ there. So these moms, when they just are mildly preeclamptic, we start to see a little bump up in blood pressure, maybe a little bit of protein in the urine. We're going to want them to, take activity restrictions, right? You're not going to be doing a lot because the more you do, the higher your blood pressure can get. Definitely paying attention to fetal movement, definitely doing some non-stress tests, looking at their urine for protein, measuring their weight. Let's have them cut out some salt, because if they're already having this vasospasm going on and fluid is going, this way and that way, we need to figure that out. Definitely having non-stress tests. We're watching these babies closely. Do you let the baby cook or do you go ahead and deliver? Always the question. So, unfortunately, some moms will end up with eclampsia. If you had to think for a second, who do you think might present with eclampsia? Think about different kinds of patients, different kind of patient history. Who might be someone who's eclamptic? All right, I'll tell you. The person who is eclamptic, let's see, who thought it? Courtney, did you decide? Lanice, did you figure it out? Brian, Kyle, Alyssa D, Alyssa M, did you guys figure it out? Someone who didn't have prenatal care, right? So if you have someone who has no prenatal care, they are the most likely type of patient to show up having an eclamptic seizure because they had no prenatal care. So there was no one watching. There was no one who could catch the signs of gestational hypertension that maybe then turned into preeclampsia, or the signs of just preeclampsia, and that they were worsening. Okay, these patients come in through the ER. And this is, not great. Usually we stabilize mom before we go ahead and deliver. I know it seems like you would crash section them, but you actually don't. They will be delivered that day, or but usually you go ahead and you try to stabilize them. Very first thing you're going to do if a mom's having a seizure when her seizure is done is what? Monitor that baby. Right? You are going to slap a fetal monitor on that baby. We no longer do any of those seizure kind of precautions like putting in an airway or restricting the mouth or holding the mom down or putting oxygen on, nothing like that. You're going to just keep her safe while she's seizing, okay? Like hands off, but keep her safe. And then as soon as she's done, let's get some oxygen on mom, right? Let's slap some oxygen on her. Let's go ahead and number one, let's get the baby on the monitor. Typically what would happen is you're going to have multiple people doing all of this at once. Someone is immediately going to start an IV line. They may go ahead and do something stronger, but what they're definitely going to do is a magnesium sulfate bolus because it's a CNS depressant and we want to cause CNS depression. So they're going to go ahead and start an IV magnesium bolus. And you're going to really watch and see what's going on. If the baby's crumping, then you are going to have a stat C-section. But if the baby seems to be okay, they may kind of stabilize mom before they go to a C-section. So anyone who has worsening preeclampsia is going to be treated with IV magnesium sulfate throughout labor. Okay, it's on a pump. You have to be two people have to sign off on it. You want to make sure you give the right amount. to decrease CNS irritability and sensitivity and prevent seizures. And then they're on it 24 hours postpartum because actually you're at risk for an eclamptic seizure up until a week after delivery. So then we always have to educate these moms on signs and symptoms, terrible headaches, seeing spots, all of those kinds of things. Because even after we stop the magnesium, they still are at risk for a week, although it's pretty rare to have a postpartum seizure. It's very, very rare. However, because the cure is delivery, right? The cure is delivery. There's a lot of research as to why some people become preeclamptic. One thing they've noticed is that if someone has a different father for a baby, that you could have it with one father and not the next. And there was actually a study done. You don't need to know this. I just found this fascinating. Though there was a study done that looked at a father who had fathered multiple different babies with different mothers. And all of those moms had severe preeclampsia, and they called them like lethal sperm. Like what was his? And so they think it may be some sort of like immune reaction. I don't know. It's super interesting. Lots of different reasons why we can't really figure out why some people develop this disorder. A lot of research behind it and ideas behind it. So when someone comes in and they're preeclamptic, things you're going to do, we always pad the side rails because we anticipate they could have a seizure. We always start, the doctor's going to order a magnesium sulfate drip. Usually they're going to be induced, so you're going to be giving Pitocin, which is to cause muscular contraction of the uterus. At the same time, you're giving magnesium sulfate, which causes a generalized relaxation of muscles all around. So that can be a little tricky. Luckily, what we found is that women who are preeclamptic seem to be very sensitive to Pitocin. And so even though sometimes they may have this rock hard cervix or be early in pregnancy, 34 weeks, 36 weeks, right? This isn't a term patient who maybe already has some effacement and dilatation going on. They seem to respond pretty well to the Pitocin. We don't know if it's like an irritability thing or what, but they seem to do that. The other thing is magnesium is excreted through urine. So we also are going to be doing hourly urine outputs, hourly blood pressures, hourly IV checks, hourly, we're going to look at someone's reflexes because they may come in very hyperreflexive, right? Because they have this CNS irritation going on. As we start to give the magnesium sulfate, we're going to see a decrease in reflexes. We need to see a decrease in reflexes. We need the magnesium sulfate to be therapeutic, right? We need to have that depression going on. We don't want to lose all the reflexes. We don't want to have her breathing at 8, but there's a fine line between your normal level of magnesium sulfate and it's going to have to be a little higher than that normal level because we need it to be therapeutic. We're looking for those, the changes that magnesium sulfate causes. So these are all different ways things you're just typically doing with a preeclamptic patient. The other thing you have to have at the bedside, who knows this? Who knows this? Who can I ask? Jeff, what do we have to have at the bedside? Megan, what do we have to have at the bedside? You have to have calcium gluconate. Calcium gluconate is the antagonist to magnesium sulfate. And these moms are being monitored, right? Because we're trying to make sure baby's handling this all okay. So she's going to be on an electronic fetal monitor the whole time. However, we need to be able to give the calcium gluconate to mom if she becomes respiratorily depressed, right? So we're going to be doing respirations a lot. These moms are going to be on pulse oxes, all of those kinds of things. Okay, so gestational hypertension can develop preeclampsia, or you just plain have preeclampsia. You have a normal lowering of blood pressure that occurs in the first 20 weeks of pregnancy, which is why sometimes this is masked and why we don't usually see this until later in pregnancy. Once someone starts to develop protein in their urine, possibly CNS complaints, seeing spots, hyperreflexia, headache, swelling, these are all signs. The triad we usually say is increase in blood pressure above 140/90, swelling, and protein in the urine. That's sort of the triad we always look at. But then we start to see some changes in lab values and things like that. The two things we're most concerned about if you have these, other than eclampsia, the other thing we're most concerned about if you have all these vasospasms going on is that there could be damage happening to the liver, okay? And so we are going to, on these preeclamptic patients, we're often going to be checking their liver enzymes And we're going to be checking their platelets because we know there can be damage to platelets too, right? So because of clotting factors and things that the liver contributes and helps us to make. So again, I don't want to go down too deep of rabbit holes, but just think you need your liver to work to help make clotting factors. And if you're having issues in your liver, you could have clotting problems. And then you're also going to have increase in your liver enzymes. So again, here's just interventions for seizures. I talked about this. But this is what I want to talk about, HELP syndrome. So anyone who is preeclamptic is at risk for HELP syndrome. HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. You start having this hemolysis of red blood cells because you're having this vasospasm happening. All of these little red blood cells are getting stuck, and now you're having your liver not working correctly, and you're having platelets drop, and you're having elevated liver enzymes. This is a worsening complication. It will lead to delivery. It can also be idiopathic. Someone can just present in HELP syndrome, which is bizarre too. They will complain of right upper-sided quadrant pain. You do not want to go in and massage that liver because if it's already having issues, right, you don't want to cause any rupture or anything like that. But you're going to feel, and if they're, gently palpate, lightly palpate, and if they are having upper right pain, you are, thinking about HELP. These moms need to deliver. The only way to cure HELP syndrome is delivery, okay? And these moms often need, they may need different kinds of blood products or platelets and things like that. They have to be watched very closely because they're at risk for what? Anytime you have a hemorrhagic condition, let's go back to what we talked about before, they are at risk for DIC, okay? So chronic hypertension is when you see it from the get-go, so you see it less than 20 weeks, and then it comes after. However, someone with chronic hypertension needs to be watched very closely for preeclampsia because sometimes it's hard to distinguish. The other one, I think Colleen was going to talk about a little bit about this too, but just the Rh factor. If you have a mom who is O negative, A negative, AB negative, okay, she has to get RhoGAM. Any bleeding from any kind of miscarriage following an amniocentesis, because that disrupts the placenta a little bit and can cause some blood mixture, at 28 weeks pregnant, and then only postpartum if the baby is Rh positive. If the baby also comes out negative, then the mom is fine. We do not trust if she says, I know my husband is O negative, we say, oh, well, you still get RhoGAM because, we never know. And it's not with the first baby, it's with subsequent pregnancies, because what happens with the first baby is the first Rh positive baby, the mom builds up antibodies against that baby, but they don't attack that baby. It's the next baby. Now these moms have antibodies in their blood. So basically you can do a test called the Klein-Hauer-Becke test. So who else might need RhoGAM? A mom who has an abruption, right? Anyone who has any kind of bleeding that causes a mixture of the maternal and fetal circulation, and that's going to cause the antibodies to build up, okay? So when you have fetal blood mixing in with mom blood, you need RhoGAM if the mom is negative. And so after something like a car accident or a trauma or anything like that, they're always going to draw Klein-Hauer-Becke on mom, and that actually counts the number of fetal cells they can see in the maternal blood cells, and there's a number that's okay and a number that's not. So it's called a Klein-Hauer-Becke. It's kind of interesting. So who gets RhoGAM? A negative mom if she has any kind of bleeding or a miscarriage, an amnio, then postpartum if the baby comes back positive. The other thing we want to look at, and we'll talk about this more when we get into newborns, is you can also have ABO incompatibility. So you have Rh, but then you can also have ABO. And basically, moms who are O naturally have this anti-A and anti-B, so those babies can be at increased risk for jaundice because jaundice is caused by a breakdown in red blood cells, and you have immature liver, and that all leads to jaundice. So we'll talk about all of that in more detail later. So here's just kind of a nice picture showing how it works. This is just a good question. Why do we give magnesium sulfate? To prevent seizure activity, right? Now remember, magnesium sulfate can also be used as a tocolytic. So you've seen this drug before when we talked about preterm labor. When you talk about tocolytic drugs, the one thing we know is that they're not research doesn't really support that they make that big of a difference, but we do still use tocolytic drugs if we want to buy time to get corticosteroids on board, right? So if a mom is early in pregnancy, we need to think about getting those corticosteroids on board to increase lung maturity by increasing surfactant production in the baby. So that's usually when magnesium sulfate is used as a tocolytic. It's to kind of just buy a couple days to get those corticosteroids on board, and hope those babies will do better. So the other thing I just want to touch on and not talk too much about, but touch on is diabetes in pregnancy. So you can have someone who's a type 1 diabetic or even a type 2 diabetic, and especially though with type 1, they can have a very difficult time with pregnancy. They need to really be getting a lot of support, seeing a maternal fetal medicine specialist. They definitely need preconceptual counseling because moms who are type 1 diabetes are at increased risk for congenital anomalies. So it's very important that a type 1 diabetic has very good blood control for the few months before they have a baby, because the better blood control they have, kind of the less chance of congenital anomalies. And it's kind of a lot to go into, but just kind of know that now. So that is different than gestational diabetes, which we'll talk about in a little bit. But what we do know is that hormones in pregnancy can create insulin resistance. So that's why it's important that these moms are really watched closely, whether they're a diabetic to start or develop gestational diabetes. The body is going to have a greater need for insulin as they get farther along in pregnancy because they have this natural insulin resistance that kicks in. We do not think that insulin crosses the placental barrier, so the only way we can keep sugar from too much sugar going into baby is by keeping mom's sugar low. One thing I meant to mention when we talked about preeclampsia is those moms, when they come in labor, we have to be careful about treating their blood pressure. You never want to bring a chronic hypertensive mom or a preeclamptic mom, you don't want to bring their blood pressure down too much because that placenta won't be perfused and you'll see uteroplacental insufficiency. And what happens if you see uteroplacental insufficiency? You see late decelerations. And what if you can't fix it? You see repetitive late decelerations. And do babies have reserves? Yes, but eventually they'll use up those reserves and need to have a C-section. So you always think about when you have a preeclamptic mom, if they get over 160 over 110 or 160 over 100 and they want to go ahead and start treating her, you'll be slowly pushing labetalol because you never want to bottom a mom like that out because then the placenta won't be perfused. It's already had this, it's used to vasoconstriction. It needs the blood to be pumping at a higher, harder rate than normal. So you don't want to drop it too low, which made me think about diabetes too. Same thing when you think about sugar in mom. Babies who are born to whether it's a diabetic mom or a gestational diabetic mom, what do we watch really careful after delivery? We watch their blood sugar. Are we concerned about hyperglycemia or hypoglycemia? Alicia, what do you think? We are concerned about hypoglycemia, right, Shaylee? Hypoglycemia, because these babies are used to more sugar. So their body and their pancreas has been pumping out insulin because the mom has all this extra circulating sugar. So all of a sudden that baby gets born, you take away their source of sugar, their pancreas is still used to pumping out all this insulin, and boom, you can bottom out their blood sugar. So these babies, moms always think, oh, are you checking their blood sugar to make sure my baby doesn't have diabetes? And it has nothing to do with that. That is not something that's diagnosed in infancy. You're checking the blood sugar to make sure the baby doesn't become hypoglycemic, which can then lead to a whole bunch of, then they can't maintain their temperature, then they're too lethargic to eat, and all those different kinds of things. So a mom with pre-existing diabetes, just like anything else, has that extra circulating sugar. This puts her at increased risk for all different kinds of things, including urinary tract infections. Sadly, preeclampsia too. It's kind of one of those that can go hand in hand with diabetes. Ketoacidosis we have to watch out for, right? Dystocia, so large baby. Really, the main reason why we treat gestational diabetes is to not have macrosomia, because macrosomia or a large baby can cause shoulder dystocia, it can cause traumatic deliveries, it increases your risk for a C-section, which we know can have more complications associated with it. So we're always thinking about big babies with diabetic moms. I talked about this. These moms should have, if they have a pre-existing diabetes, they really need to have conceptual counseling if at all possible. Things that babies are at risk for, hypoglycemia being the biggest one. So who develops gestational diabetes? Well, if someone is overweight to start, if they're a little bit older in age, they've had it before, if they have a history of it in their family. So we screen all moms for Hispanic moms are at increased risk for gestational diabetes. I don't know why, just one of those one of those things. So that's one of the ethnic groups that is at more increased risk for it. So how do we identify gestational diabetes? Every mom at 28 weeks is screened for gestational diabetes. We have them do a glucose challenge test. They have to drink a bunch of stuff. We take their blood an hour later. If it's still high, if it comes back high, then we actually do a test where they do a 3-hour glucose challenge test and see how it is. If it's still elevated, then we start treating them for gestational diabetes. They're always going to start with diet. Let's, watch their carb intake, see if we can keep them at a good blood sugar, increase some walking, things like that. Having them check their blood sugars. We know that these babies can be at increased risk for all different kinds of things, so we need to be doing some non-stress tests. These are the moms who are getting biweekly non-stress tests, okay? But why do we care? Because it can lead to macrosomia and shoulder dystocia and traumatic delivery and all different kinds of issues. If diet isn't working, these moms will get insulin. So they are seeing the doctor every week, if not twice a week. They're getting biweekly NST, so they at least have to come in for that. Usually starting at 28 weeks, they're getting blood drawn, all different things like that they have to be monitored for. Sometimes gestational diabetes goes away. Cure is delivery. Get rid of that placenta. Cure is delivery. They will check them again at their postpartum appointment. If at their postpartum appointment their blood sugar is still high, then they may have developed like type 2 diabetes. And a mom who has had gestational diabetes is at increased risk for developing type 2 diabetes later on in her life. We always want to look at, some people will have different anemias of pregnancy. I don't want to go too much into this. However, we always want to think about that folic acid. And remember, we tell moms to take 400 micrograms a day prior to getting pregnant and during their pregnancy. But your doctor is going to be monitoring for anemia. They do blood twice throughout pregnancy, and they'll do it more often if they're concerned. The last thing I want to talk about is infections that can occur during pregnancy. Viruses can cause a lot of bad things, especially early in pregnancy. This is why we do not give the rubella, the measles, mumps, and rubella vaccine while someone is pregnant. We test for rubella during pregnancy. If they are not immune, we will give it to them before they're discharged from the hospital. It is a live vaccine, but all of these different kinds of vaccines can cause issues. So from all different kinds of, anomalies and things like that. So the things, it's really important that we talk about torch infections, and this stands for toxoplasmosis. And then O stands for syphilis, varicella, and parvovirus, rubella, and cytomegalovirus. And then herpes can also be a common infection associated with congenital anomalies. And babies can actually get systemic herpes and die from it. They can die of sepsis from that. So if a mom has an active herpes outbreak, she absolutely cannot deliver vaginally. She will have to have a C-section. So active herpes outbreak, you absolutely have to have a C-section. A lot of these moms are going to be treated with acyclovir during their pregnancy to prevent them from having an outbreak. What's hard is if someone gets a virus, there's not a lot you can do. Some will actually cause miscarriage. So we really just need to do education to moms about that. So remember the kitty litter, having moms know they shouldn't change kitty litter, and having mom, things like that. So I think it's toxoplasmosis is with the kitty litter. Parvovirus, I believe, is fist disease. So you want to keep moms from, when you're early in pregnancy, a lot of moms who are pregnant and teach preschool and things like that, we really have to be talking about hand washing, and if there's a child sick, you don't bring a sick child that might have a virus around a mom, especially in early pregnancy. HIV, again, we test moms twice throughout pregnancy for HIV as mandated by the state of Illinois. We have a whole process that is followed. A lot of the protocols were actually developed at Northwestern way back in the late 90s when I was a nurse there, and they have great success if they can get a mom's viral load to be very low at the time of delivery, and then they treat baby with an antiviral post-delivery, and have had very good success and not seen HIV then in the babies. But again, an HIV positive mom, what's the one thing you're definitely not going to be doing? internal fetal scalp electrode, right? You don't want to do anything that would nick or, put a nick in the baby's skin. So the other last thing that we screen all moms for, at 36 weeks of pregnancy, they go ahead and they swab mom's vagina and rectum for what's called group B beta strep. Group B beta strep naturally occurs in the flora of the vagina. It can come and go. And so it's not something that you, toxoplasmosis, yes, is it's non-viral, but you get it from raw meat and cat feces. So that is the one that you don't want moms changing kitty litter. So all moms are tested for group B beta strep at 36 weeks. We tell them this is not a sexually transmitted disease. You don't need to worry, or be concerned that something's going on with your partner. But it was one of the biggest causes of infant sepsis, to the point that enough babies were dying from sepsis from GBBS that the CDC put out standards, and you can actually go to their website and see their GBBS protocols. So all moms are screened if you are positive or unknown. So you come in with no prenatal care, then you're just going to be treated like you have it because you can't get the results back in time. These moms are treated with IV antibiotics during labor. They try to get 2 doses in. If they don't get 2 doses in, then they have to and all these babies will be monitored very closely after. And if they show any signs or symptoms, they will be treated with antibiotics as well. So there's a whole protocol that's followed to prevent neonatal sepsis, and they've had a dramatic decrease in neonatal sepsis. Tuberculosis during pregnancy is going to require a whole bunch of different stuff because you need a negative air pressure room. So I'm pretty sure Northwestern has a few L&D rooms that are negative air pressure. And there's, I think the baby has to be separated from mom, but I would have to double check that. But again, just infections that are going to need a lot of hands on deck if mom has this during pregnancy. So you guys can go ahead and read this question, and I highlighted right the right answer is. So if you want to spend some time looking at that. All right, that's it for today. Thanks, guys.